Good afternoon, everyone, and welcome to today's webinar entitled Successful Post-Operative Pain Management Using an Opiate-Sparing Regimen. We're so glad that you could all join us as we have a wonderful presentation in store for you today. My name is Deanna Fenton, and I'm the Program Manager for the Alliance. Now, we do have just a few logistical items to review before we begin today's presentation. For those of you who have never joined us on this webinar platform before, the chat feature is located in the bottom left-hand corner of your screen. If you have any questions that come up during the webinar, please feel free to submit them at any time. Once the presentation is complete, we'll have some time for our presenters to address as many of your questions as time allows. As an added note, throughout the course of today's presentation, there are 4 videos that will be shown. The sound from these videos will come through your computer rather than your phone. So if you are dialed into today's webinar via phone, please be sure to turn up the volume on your computer speakers so that you'll be able to hear the discussion. Registration is currently open for our next webinar entitled A Breath of Fresh Air, Approaches to Doubling Lung Utilization. That's coming your way on April 9th at 2 p.m. Eastern. Registration is also open for our next webinar entitled Why Does Social Support Matter for Transplant? That's coming your way on April 25th at 3 p.m. Eastern. You can register for all of these webinars and more at our website at organdonationalliance.org. Now, for those of you who are interested in continuing education credits, we are offering 1 CET-C credit and 1 nursing contact hour. Everyone listening to today's webinar is entitled to claim these credits. If you're listening in a group, as many of you are, please be sure to get the evaluation email from your group lead. It's a very brief online evaluation which will allow you to receive your credit. As a reminder, for nursing, you have 14 calendar days to claim your credits, and for CET-C, you have 30 calendar days. Now, at this point in time, I'd like to introduce our moderator, Tiffany Buda, Clinical Manager at Cleveland Clinic. Tiffany, we're so glad to have you join us today. At this point, I'd like to turn it over to you to introduce both of our speakers.
Thank you, and thanks for the invite to allow us to present to you guys today, to everyone today, and thank you to all who have joined us. I would like to introduce our topic, and this was an interesting topic that had come about out of necessity. So the topic today is to discuss successful and reproducible post-operative pain control using opioid-sparing regimen. And the focus is in LVAD patients, but we've progressed this further into our transplant patient population. And this project came out of identifying a need based on seeing that our patients were being treated and obtaining medications, opioids specifically, from outside providers. And knowing the opioid epidemic that's going on, we wanted to do all we could to help get our patients off of opioid medications. So your 2 presenters today, Kay Kendall and Kim Miracle, led our efforts here at the Cleveland Clinic, and they're here today to share their experience and process in hopes of helping others if you see the same need. So real briefly, I want to introduce Kay Kendall. She's been our transplant social worker here at the Cleveland Clinic for the last 30 years. She is well known. She has published both articles, book chapters on transplant, mechanical circulatory support, a lot of focus on psychosocial assessment and quality of life for both pre- and post-transplant patients. She's served on many committees and has presented to both the national and international conferences about psychosocial aspects of heart transplant and mechanical support. Most recently, she was one of 6 leaders involved with the publication of the ISHLT consensus document titled the 2018 ISHLT APM, AST, ICCAC, STSW Recommendations for the Psychosocial Evaluation of Adult Cardiothoracic Transplant Candidates and Candidates for Long-Term Mechanical Support. She's been a member of the Society of Transplant Social Workers for 25 years, and of those, 23 years were spent as a board member, so very involved in our transplant organizations. And then Kim Miracle is our advanced practice nurse practitioner, acute care. She's been a nurse for 23 years and has cared for patients in cardiothoracic surgery for the last 12 years. She has vast experience in the management of cardiothoracic patients, both as a nurse and as an NP. She's been on the Mechanical Circulatory Support Service for 11 of those years. In her role, she manages pre- and post-surgical patients undergoing evaluation and treatment with left ventricular assist support, and she's presented on topics of LVAD and participated in research, and her research has led to publications as well. She demonstrates compassion and passion for her patients. So without any further information, I'm going to let Kay go ahead and get started.
Thank you, and Kim and I are very happy you're able to join us today. And we're looking forward to sharing a project that has involved a great deal of time, and I don't want to overuse the word, but has certainly involved a lot of passion on our part. Excuse me, something we've cared a great deal about. The next slide, please. The objectives of our presentation today are to discuss the results of an opioid-sparing regimen with our left ventricular assist device population. As Tiffany mentioned, we are also now using this pain management technique with our post-transplant patients, and throughout our presentation we will attempt to comment on that process also. Secondly, and you're going to hear in some of the interviews that were mentioned, but also in our dialogue, the importance of having conversations with patients about management and expectation of pain. I don't think Kim and I had any idea when we began this project about the power of talking and conversations with patients and how much that can bring about change. I think this project also is just an excellent example of identifying a problem, learning then about the extent of a problem, developing a plan, implementing a plan, and then learning about the results of the effort. Why are opioid-sparing pain regimens needed? So it is obvious to us in everyday life with reading and newspapers, hearing on news about the tragic deaths of many individuals because of drug overdoses that have involved opioids. Interestingly, in 2013, there was a marked increase in overdose deaths with the use of synthetic opioids, fentanyl, tramadol, or Ultram. I have been very surprised by my work here how many individuals do not realize that tramadol is in the opioid family and feel that that is an okay medication to prescribe for chronic pain. I think another example for those of us working with different aspects of transplant is the increasing use of drug overdose donors as the U.S. opioid epidemic has grown. So I want to talk a little bit about how this problem was identified. And the national crisis or epidemic was really not specifically what raised concerns. I think it helped us have our work recognized and accepted, and the efforts we were making accepted, because there is the knowledge and the concerns of opioid dependence is so prevalent. As a social worker with both heart transplant and the Mechanical Circulatory Support Team, I see patients when they're being evaluated. I follow them while they wait, when they have a procedure, and then I continue to follow them in the outpatient clinic. And it was really in the outpatient clinic, when I was seeing this group of LVAD patients, that I began to wonder, when I would talk with them, why so many of them, or what seemed to be so many of them, were being prescribed opioids for extended times after surgery, after their acute pain experience. This could be a month, 2 months, a year, and sometimes even as long as 2 to 3 years, with really no questioning of that. I began talking to team members about my concerns. I was concerned about the hands-off deferral process that was currently in place, and importantly, it was very comfortably in place. I rocked the boat, and I think there were many times I would not have won a popularity contest for some of those weeks as I continued to talk and verbalize concerns about this ongoing use of opioids. So why would questioning pain management status quo even rock the boat? It is easier to defer pain management to someone else, anyone else. It is easier to not question pain regimen choices. It is easier to interact with happy patients, and it is easier to avoid taboo conversations with patients. People do not want to talk about pain management. So I realized I needed to stop talking, stop kind of making a pest of myself, and really determine, was this problem as large of a problem as I thought it was? About this time, one person who did not tire of my conversations and who was so supportive was Kim, who you are going to meet shortly. She shared my concerns, and we began talking about this process and what was going on, and really the need to learn how extensive this problem was. We reviewed charts, and we identified over 50 patients, these were after discharge from the hospital, with active opioid use. At that time, that was 30% of our LVAD patients. We began talking about a plan of action and the need we would have to involve team members. So as I mentioned, Kim became involved, and for me, as a social worker with the team, it was so helpful that I no longer felt quite so alone. Also, there was the benefit of Kim's medical knowledge, and I think it helped establish support from team leadership. So our next project was really to learn about who were pain management expert specialists within our Cleveland Clinic system. So I really didn't know the answer to that. I began by talking to other people, by asking about pain management specialists. I contacted them. Some I maybe spoke to on the phone, some I maybe emailed, but several people had face-to-face conversations with. And one I will remember, we had originally planned to talk for about an hour. I think we spoke for about 2.5 hours the first time. And that was a Dr. Jimenez, who is the director of our chronic pain rehabilitation program here. He listened, he validated my concerns, he supported me, and very interestingly and importantly, he helped explain how different disciplines would approach pain management in different ways. And that was extremely helpful that he was able to do that. I'm going to mention him again in a moment, but that conversation really was so instrumental in what our next steps were. We made contact with the department chair of pain management, Dr. Richard Rosenquist, who continues to work with us on our efforts. We met with the medical director, who was the medical director at that time of our heart failure program, Dr. David Taylor, who was very supportive of our efforts. And Kim and I met frequently, and we talked and talked and talked. And some days I think we felt like maybe nothing was happening, but things were happening. We would frequently frequently speak of, after a meeting with Dr. Jimenez or after a meeting that we would have, we would describe it as one of our we could climb a mountain moments. It was motivating and really reinforcing, and kept us focused on this, and that we were not going to give up these efforts. So we continued contacts with Dr. Jimenez. there are a total of 5 nurse practitioners that work with our LVAD team. And so Dr. Jimenez wonderfully agreed to teach 4 1 to 2 hour presentations for our LVAD nurse clinicians. He educated about basic concepts of pain, pain management, and introduced an opioid-sparing technique. We began looking at our long list of patients who had long-term use of opioids. Dr. Rosenquist became involved additionally at this time, because that list seemed like it was a mountain high, and we had to try to figure out how we could make some changes with that. Both of these individuals reassured us that in using a different approach, we weren't going to have that many people who were opioid dependent. We also recognized that this was a sensitive situation. We were changing a way that we were managing pain, and there were differences with how team members perhaps came on board with this and were accepting of these changes. We also realized that we needed to develop a department standard regarding opioid use, and this was another project that we worked on. We needed this because we needed a standard approach for our team members to take, but also in teaching our patients. In 2016, the Center for Disease Control published their opioid guidelines, and that guideline, along with a number of other policies and procedures, was really instrumental in our how we formed and developed these team guidelines. So we worked for many, many months. Dr. Jimenez, Dr. Rosenquist, Dr. Taylor, and also very importantly, our legal department reviewed these guidelines. They tweaked and made some suggestions about wording, which we did. This was sent out to all team members to review. And in October of 2016, Dr. Taylor presented at one of our team meetings the guidelines, and these guidelines were adopted as our team policy. We also developed opioid team guidelines for patients, and that was for individuals who were using an opioid at the time we were meeting them. And so it again gave us a standard we could refer to in the ongoing management of pain for our heart failure patients. After those 2 guidelines were established, we then developed a opioid patient agreement document, or a patient education document. And this was to help educate patients about pain and that they would have after surgery, how their pain was going to be managed. We educated them about opioids, and this is I'm very happy to say, now used routinely with all of our LVAD patients when they are being worked up for surgery. The document is reviewed with them, signed, and scanned into their electronic medical record. So this has become just a norm and a protocol with these patients. I apologize, I went a little bit ahead on that, I'm sorry, but that basically I just described these different documents. So I have an example of Kim reviewing with a patient the patient education document. And this is, I think, a wonderful example also of the power of communication with the patient.
Part of the recovery after a surgery is managing your pain. We know it hurts when you have a big surgery like this, and everybody experiences that pain a little bit differently. But we're going to talk about this every day while you're on the regular nursing floor. And our goal of therapy is to try to transition you off of the very potent pain medications, which are called opiates, onto a regimen that doesn't involve opiates, okay? Right now, you are getting a very potent pain medicine. It is a great medicine for helping with surgery pain, but it's typically best used for short periods of time to kind of get you over the pain part that is most severe. And then every day, as your pain is getting better and better and better and better controlled, we'll get you off of that medicine altogether and likely onto a regimen of medicine that doesn't involve opiates, okay?
Okay.
Right now, you were transitioned out of the ICU on oxycodone, which is a great medicine. It's scheduled every 4 hours. You have to ask for that if you need it. Tomorrow, we're going to decrease that to being every 6 hours available to you. Then the day after that, every 8 hours, then every 12 hours, and then we'll be off of that medicine altogether. While we're coming down off of that medicine, we're going to incorporate non-opiate pain medicine that typically includes medicines like Tylenol and Gabapentin, lidocaine patches, increasing regimen of those as we're decreasing your opiate pain medicine. Now, this only works if you're honest with me and telling me if this is working. If you are experiencing pain as I'm coming off of the opiates, you need to tell me that because we need to increase the other non-opiate pain medicine, okay?
Okay, so essentially we're trying to get me to transition
Off of the potent pain
high-powered
medicine,
stuff
the
and
opiates.
into-
That's right. Our goal is to definitely have all of that off before we discharge you from the hospital. All right? What I've got for you today is an education tool that our department has put together so that you have an understanding of what our standards are in managing your pain. This is a group effort in getting your pain under control, and we want to make that work. I've got a responsibility to you, and you have a responsibility to let me know if we are doing well or not doing well, okay?
Next slide, please. So as we talked about the goals of our presentation today, it really all starts with a conversation. And again, as I mentioned earlier, I don't think Kim or I had any idea how significant and impactful having conversations with patients would be.
It's a taboo conversation to have with people. Nobody loved to talk about opiates and addiction because patients feel there's almost a sense of accusation with that. So it was very difficult to kind of choose the right words. So it didn't come across as an accusatory conversation. And we had no practice with it. So with more practice, I came down with my spiel and the conversation just flows. And again, it's a conversation you don't just have one day and you don't bring it up anymore. You have a nice education piece one day, but we're talking about pain every day on every patient. So it eventually just flows. But in the beginning, it was tough.
So it starts with having a conversation, and as Kim mentioned, this isn't a one-time conversation. It's repeated conversations about pain management, and that these conversations are key in changing the practice of pain management. I've certainly noticed in my own practice as a social worker that I talk about pain and discuss with patients much more often than I'm sure I did 2 to 3 years ago. And I think this is one of the ways we've seen it change also with both our pre- and post-heart transplant patients. And not just my changing, but also the nurse practitioners that work with that population.
It is impressive what you can do with reduction of opiate use with a simple conversation. Laying down expectations, acknowledging that they're going to hurt, offering a plan for how to manage the pain in a safe way, and we
reduce opiate burden in our own population by an incredible amount in a very short period of time, just by being willing to have a conversation.
As Kay had mentioned earlier, when we identified that 30% of our patient population was continuing to receive or require chronic opiate prescriptions long after their acute pain period should have passed, we recognized at that point that we had committed a great disservice to our patients through our lack of involvement and our inaction in their pain management. The reasons that our team was more than happy to allow any other provider to take over our responsibility for managing their pain was for two primary reasons. One, we were not very good at managing pain, especially if it didn't already involve an opiate. We did not know what the alternatives were, so it was easy to prescribe what we knew would work. And two, we were not very good at having uncomfortable or taboo conversations with our patients about their pain control and opiate use, which was crazy because these were complicated patients, and we were already talking to them about a lot of complicated issues such as death and dying, complications associated with their medical care. We were even talking about intimacy or sexual dysfunction, their marital discord. But for some reason, when it came to wanting to have a conversation about pain control or their use of opiates, we would freeze. You have to remember that these patients were having pain related to surgeries and incisions and procedures that we had placed upon them through wounds and hematomas that we had left them with. They were experiencing real pain, and yet we just relinquished our responsibility to take care of their pain and handed it off to whoever these patients could find on their own. It was ended up being their primary care doctors, internal medicine doctors, palliative medicine professionals. Sometimes they actually got plugged in with chronic pain specialists, but we had kind of left them high and dry to find anyone that they had relationships with to manage their pain. When we eventually decided that we were going to resume our management of their pain, we were having conversations with the providers that had been prescribing those pain medications and had been managing, and we were finding some astounding facts, primarily that the majority of the prescribers at that point were providing very few face-to-face evaluations. It would be months between face-to-face visits that these providers were having as they were continuing to prescribe opiates. Patients were not receiving information, educational material about opiates. They were not receiving information about the risks of opiates. They were not being told what alternatives to opiate use could be, and which just reinforced in my mind that we were not the only clinicians out there who were completely unaware of what opiate-sparing techniques could be offered to our patients. And the vast majority of our patients were receiving zero oversight. They were not receiving toxicology screens. They were not going through pill counting episodes, and they were not being monitored, or no one was paying attention to whatever the states were doing as far as monitoring opiate use within the states. In short, our inaction was what created this epidemic within our own population, and we decided that it was high time that we take back our responsibility for managing the pain that we created. Stay on this slide, please. When we began this initiative several years ago, we had no idea what to expect. We did not know what the options were. As Kay had mentioned, we did not know what the possibilities were within this population because there was no education, no information available to guide us in any way. We did not know whether this was possible in our population. For those of you who are not familiar with LVAD therapy, this is a device that is implanted within their chest with a cord that is threaded or snakes through their abdomen and exits their body, and it's a permanently placed device for those who have this to the end of life, and it's still placed in their body for a prolonged period of time while they're waiting for transplant.
We also did not know who, in the beginning, our pain experts were going to be. What we did think at that time was we could potentially make an impact on the amount of opiates that were being required in the acute phase of pain. And we also thought that we might be able to identify like-minded specialists who could mentor us, who could teach us about opiate alternatives, who could help us in the management of our difficult acute pain referrals, and would help us in assuming care for our chronic pain referrals. Knowing what we know now, this is the goal statement that we would have established back then. We would manage acute pain in a responsible and collaborative manner through the integration of non-opiate alternatives for the purpose of reducing the number, can you go back? The number of LVAD patients who transition to chronic pain diagnoses, who require chronic opiates, who would go on to develop an opiate use disorder, who may potentially be at risk for overdose, reduce the number of LVAD patients who would be involved in opiate diversion, and reduce the number of LVAD patients who could experience adverse events and effects related to opiates. Next slide. The management of acute pain. Within our population, we work a lot with surgeons. We cut on people intentionally. We know that the interventions that we provide to a patient are going to be painful, and if we did 100 surgeries on 100 different patients, we were going to have 100 different pain responses as a result. Regardless, when we create a pain through a surgery that we cause, we are the ones responsible for the management of that pain from the onset of the pain until the patient is at a comfortable position with their pain. We find that patients don't like pain surprises, especially in the post-operative period, and it was always best to be upfront and honest about the pain experience we thought a patient might have. You have to be honest and tell them that they are going to have pain after a painful procedure, and that is a normal thing to expect. Remind them that with every passing day, the pain should be expected to get better every day. And you teach them that there are many things that could impact their overall pain experience, not just the surgical pain that was created, but many things like constipation, urinary tract infections, if they were sleeping poorly, if they were actually moving poorly, if they had chronic pains that they were bringing into this surgical experience. All of these things taken together could have a huge impact over their overall pain experience. And you can see where it can be challenging to fully understand a patient's post-operative pain through a simple score of 0 to 10. We wanted to do this in a responsible and collaborative manner, but we didn't know what it meant to actually manage pain responsibly. We felt like it probably meant two primary things. We wanted to seek out like-minded pain experts who would educate and mentor our team, and we needed to look for expert guidance from other sources. We specifically looked at the CDC recommendations of 2016, for those of you who are familiar with that. This was recommendations for the management of both chronic and acute pain. And in the state of Ohio, we were looking to the Governor's Cabinet Opiate Action Team for guidance. Again, for those of you who aren't familiar with the CDC document, it's a pretty lengthy document, but it's actually a wonderful document because from beginning to end, it's actually entirely relevant and applicable in its guidance for the management of both acute and chronic pain. If you don't have time to go through the entire document, then I would have you forward to the end of the document where the CDC provided 12 recommendations. A few of those I'm going to mention now. They recommended that opiates should be combined with non-opiate alternatives. They recommended that prescribers do discuss the risks and benefits of opiates with their patients. They recommend to discuss the individual or separate patient and clinician responsibilities that we each bring into the management of pain. They recommend the establishment of treatment goals with all patients. They recommend to reevaluate the risk factors for opiate-related harms before you prescribe anything to a patient, and this would be looking at any prior opiate use or abuse they might have, whether they have conditions like obstructive sleep apnea that could be impacted by opiates, if they have an age greater than 65, any psychological distress, if they have any prior opiate use or benzodiazepine use. They recommend that clinicians use their state prescription drug monitoring systems to evaluate what patients were using prior to meeting and certainly prior to describing opiates. They recommend curbing and controlling the long-term opiate use, that curbing or controlling long-term opiate use begins with the effective management of acute pain. I'm going to say that again. Curbing and controlling long-term opiate use begins with managing acute pain. So if you do a good job of managing a patient's acute pain, then you are going to decrease the number or percentage of your patients who would ultimately transition to a chronic pain diagnosis. The last recommendation I'm just going to read, quote unquote, what they had written. And their recommendation was to prescribe no greater quantity than is needed for the expected duration of pain severe enough to require opiates. The interpretation of that is not all pain is severe enough to require opiates. You don't have to pull out your biggest hammer for your tiniest nail with every pain complaint a patient has. Next slide. We wanted to do this through the use of non-opiate alternatives. It was important for our team to understand both medicine and non-medicine forms that could be used with our patients as we were trying to transition them from opiates to a non-opiate regimen. The medication alternatives that we primarily used were Tylenol 3 to 4 grams a day, anticonvulsants such as Neurontin or Lyrica, and lidocaine patches at the incisional sites. We also wanted, as part of managing any other complaints that patients may have with regard to sleep or chronic pain or muscle stiffness, we were also prescribing, making sure that we were prescribing any sleep medications. Primarily, we were using melatonin or trazodone to help them sleep at night. And again, using muscle relaxers to target muscle-related pain is completely separately from their surgical pain. The non-medication alternatives that we most often included were heat and warm compresses, Reiki therapy or massage therapy. It cannot be overemphasized the role that physical therapy and mobilizing patient would play in their recovery. Our patients were receiving counseling on a regular basis from social workers who they were assigned to, and that was something that started in the inpatient setting and would be continued to the outpatient setting. And for some patients of faith, pastoral care was beneficial. And again, all of this was for the purpose of 6 things that we wanted to decrease. Our patients who would transition to a chronic pain diagnosis, our total number of patients who would require chronic opiates, our patients who would develop opiate use disorder, who would be at risk for overdose, those who became involved with opiate diversion, and reducing the number of our patients who could experience adverse events or effects related to opiates. What you see is just a very typical guide for what we would use for opiate tapering. Again, with our patients, we began having these conversations as soon as they reached the regular nursing floor. Because the ICU was such a period of flux, we thought we had a little bit more control and engaged patients once they got to the regular nursing floor. And as soon as they hit the floor, we reinforced our conversations about opiate tapering, and every day we were coming down on opiates, but we were also, through our conversations with them, titrating the non-opiate alternatives. So what did we see change over time? This graph illustrates the changes in the provision of opiate prescriptions from quarter to quarter in our two populations. The light blue is our primary opiate population. This is where we were using opiates as our primary pain medication. And then our opiate-sparing population represented in the dark blue. We evaluated all of our LVAD patients over a 48-month time frame, including our sternotomy or thoracotomy approaches, all of our LVAD exchanges. And we only excluded LVAD patients who did not survive to discharge, and a total of 14 patients who were considered outliers due to their complicated and prolonged length of stay. The reason that we had to go back 30 months in our light blue population, or our primary opiate population, versus only 18 months in our dark blue population is because around the same time we instituted our opiate project, we also began increasing our total number of LVAD implants. The primary opiate population represents a total of 97 patients, and our opiate-sparing population also represented a total of 97 patients. Are you able to go back to the previous slide? The first quarter represented in the graph, the bar all the way to the extreme left, we saw 92% of our LVAD patients being discharged with opiates. Conversely, in the 16th quarter, or the bar all the way to the right, we saw no LVAD patients being discharged with opiates that quarter. Another quarter that I want to point out is the 10th quarter, or it's the final light blue bar that you see. We noticed an uncharacteristic decrease in the opiate prescriptions that quarter in particular, and we weren't entirely sure why all of a sudden, before we had instituted any intervention, that we saw such a decrease that quarter. And it took some thought to figure out why that actually occurred. And what we remembered we were doing is, during that quarter, we knew the quarter where we were instituting our opiate-sparing regimen was coming up next. And even though we could not provide our patients with our education tool, we couldn't actually actively start transitioning them to non-opiate pain medicine, what we did begin to do was hone a conversation with the patients. And we did that because we kind of felt like we needed to practice a conversation or just a dialogue with patients so that we were prepared for the following quarter. And that quarter reflects why Kay and I cannot overemphasize the importance of having pain conversations or dialogue with our patients. Look at the decrease in that quarter with just a conversation. It just reinforces that you can go a long way if you're having a reasonable conversation with a reasonable patient. Okay, next slide. Our discharge medication choices did change over time, as you see illustrated in this graph. The choice of discharge medications between our population managed primarily with opiates and our population managed with opiate-sparing techniques changed significantly. We saw our biggest changes in how we utilize three particular medications, gabapentin, Tylenol, and opiates. We saw an increase in our gabapentin discharge prescriptions from 18 to 45%. We increased our Tylenol discharge prescriptions from 52 to 79%. And we reduced our overall opiate discharge prescriptions from an average of 81% to an average of 16%. Next slide. Because of the increase of gabapentin in our opiate-sparing pain regimen, and because of the increased government oversight in the prescription practices of gabapentin also, we thought it was important to go back and understand exactly how much gabapentin our patients were requiring as we were tapering off of their opiates, because we didn't want to just trade one devil for another. You can tell, as illustrated by this graph, that there was a lot of variability in the required total daily gabapentin dose. Of the 45% of LVAD patients who were discharged with gabapentin, and I just want to reinforce, 55% of our LVAD patients were going home with no gabapentin at all. So this is less than half of our population requiring any gabapentin. Of 76% of those who were requiring gabapentin were requiring 900 milligrams or less per day. 42% were being discharged with 600 milligrams or less per day, and that kind of divides out to about 200 milligrams TID, which is a pretty low dose for those of you familiar with gabapentin dosing. Next slide. All of our efforts would be for nothing at all if we were not managing the pain. I can't overemphasize that, yes, part of our goal was to decrease opiates, to see if that could be done in our population in the post-operative period. That was a goal. But if we didn't achieve an adequate pain score from our patients as we're decreasing their opiates, then we've really done nothing. And what this slide shows is that that opiates were not a superior pain management technique in this LVAD population. It was not. At a minimum, the opiate-sparing technique appears comparable to opiates in its delivery of pain control post-LVAD patient. Now, some of you might wonder where we were getting these pain scores from. These were pain scores that our bedside nurses were actually collecting from LVAD patients through their regular routine checks and documenting in the electronic medical record. So again, this initiative that we put forward did show that an opiate-sparing technique was at least comparable to opiates in its delivery of postoperative pain in LVAD patients.
So how did this happen? I think as we look back, it was really a number of different things. I think the fact that we got to a point of having a unified team approach was essential. Those guidelines helped tremendously. The support of leadership of our team helped tremendously. Developing those department standards, again, as we've said many, many times, the repeated conversations with patients had a great deal to do with why this happened, and the ongoing education about the risks versus benefits of opioid use.
The way that we got these patients off of opiates in a timely fashion, and the way that we prevented needing to send them home with opiate prescriptions, was having a conversation. That's all we did. Hey, this stuff we have to pay attention to because it is hurtful. In case you haven't noticed, turn on the TV. Yeah. It is hurtful if someone is not paying attention. We care about you. We are going to pay attention. But I need you to understand there's a way to do this. Having that little conversation that doesn't take very long, that's where the biggest amount of progress was made as far as getting these patients off of opiates. It wasn't that we came up with some new way to taper opiates. We didn't come up with that. We sat somebody down and said, hey, this is what we found out. This hurts people. Hang in there with me. I know you hurt, but we're going to do this a different way. And they do. They actually trust that you're going to do the right thing.
So our goals as we continue to work on this are really to continue the responsible management of acute pain and continue to expand our efforts with pre- and post-transplant patients, continue the education for opiate prescribers, And again, the continued work we're doing with our patients, as Kim has mentioned, using consistently and reviewing the drug monitoring system with our patients. And also, and I think we have seen change with this, but the final point of the routine integration of non-opioid alternatives for pain management. I think we both would say we have felt so rewarded and fulfilled from this project. It is amazing and wonderful to see that how identifying a problem, implementing a plan, developing a plan, implementing it, and then looking back at what has worked can create change. Thank you.
So thanks, Kay and Kim, for a wonderful presentation. Looks like we have some time for questions, but there is one question. You know, I had said at the beginning, you know, how do we tie this into our transplant patient population? So one of the things, you know, I'd be interested in hearing about is how was this rolled out with your heart transplant or post-heart transplant or any patient? Well, our population is hearts, but how did you do it for?
So I think as I work with that population, you know, first of all team members were aware of these guidelines. So this was not isolated. This really impacted both LVAD and pre and post. We one thing we began looking at was if we evaluated a pre-transplant patient who was using a chronic opioid and they were stable, could be referred to a like-minded pain management specialist. We were doing that, and we were weaning them from opioids before they would be considered for listing. We had several patients, interestingly, who were very ill, were not able to discharge. They were waiting in the hospital, and we had chronic pain management see them in the hospital. And we had a patient just recently, a few months ago. They were completely weaned from opioids before they had their transplant surgery. Post-transplant, I will share, I think there perhaps was a little resistance initially because, again, it was a group who was used to managing pain in a specific way, and people, again, don't always want to relinquish some of that. Relinquish may not be the best word, but it takes a bit to wrap your head around change, and I think that took a little bit of time to happen. I think in the last 6 months, we haven't looked at the number of patients discharged on an opioid, but I think compared to a year ago, it would be a noticeable decrease. I can say, because I can see them at time of discharge, it is very rare a patient would be discharged with an opioid after a typical 2-week hospital stay post-heart transplant.
And I think that was one of the questions that was posed. I see here our patients weaned off opioids before discharge. And I think, you know, commenting on the transplant population and the LVAD population, for the most part, you know, they are not discharged on opioids. There's a question posed about tramadol. Tramadol is listed as a non-opioid analgesic. Why are we listing it as an opioid? Do you want to?
So I mean, I'm not sure where the confusion is. Tramadol is a synthetic opioid. It's a Schedule IV controlled substance.
Okay. And then another question that's posed is, what is the restrictions with gabapentin, and why is that?
So I don't know outside of the state of Ohio where individual states lie with restricting or monitoring gabapentin use, but within the state of Ohio, probably 2 years ago or so, the state of Ohio, in addition to all opiates, also began monitoring the use of gabapentin because of its separate concern for abuse. So, again, we wanted to make sure, as all of these medications were being monitored, that we were also monitoring its use to see whether or not patients were actually requiring high doses of this and whether they were requiring prolonged doses of gabapentin.
Kim, if I can ask you too, I recognize you don't follow the patients in the outpatient clinic, but if they are discharged with a gabapentin, that nurse practitioner certainly continues to monitor, and the goal is to, as they recover, to decrease and stop the use of the medication.
Right.
If possible.
Right. So at the time of discharge, again, we are having conversations with our patients every day while they're in the hospital, and we're also going through the discharge process with them, which includes, again, a conversation about their pain control that will be followed in the outpatient setting. And we give them a tapering dose of gabapentin at the time of discharge. But one of the advantages of our follow-up regimen is that we are following these patients weekly for a period of time. So in the outpatient setting, we are actually having weekly face-to-face conversations with our patients regarding their pain control. And, sometimes patients may require an extension of gabapentin, but a lot of times I would say they are not requiring gabapentin for as long as it's being recommended for taper.
So another question just came in about how do you wean the gabapentin, so to lead into your...
Okay, and I assume this is in the outpatient setting. So, for instance, it's one of the advantages of gabapentin. It's typically dosed 3 times a day, but this is part of the conversation you're having with a patient. Patient may not want it 3 times a day. A lot of our patients would like it at nighttime, without any doses during the day, or might want a single dose during the day and, a higher dose at night. So part of the daily conversations we're having with these patients get continued at the time of discharge. If I'm discharging them, let's just say, on what we were saying, 600 milligrams a day or 200 milligrams TID, then at the end of 7 days, we may decrease that to 100 milligrams TID and for another 7 days and then stop. But again, with the patient, you can, if you're, again, having a reasonable conversation with a patient, you can establish a taper, whether or not it's decreasing TID doses or decreasing from TID to BID to daily to off. That's in a conversation with your patient individually.
Great, thank you. I don't see any further questions, and we're coming to the end of our allotted time. I want to thank both Kim and Kay for putting a nice presentation together for our participants. Thank you.
Yes, and I'd just like to echo that on behalf of the Alliance. I'd like to extend our sincere thanks both to Kim and Kay, as well as you, Tiffany, for your time and for sharing your expertise on this topic. And to all of our participants, we thank you for your time, and we wish you a wonderful rest of your day. Take care. Thank you.